Hi, my name is Doug Wisner. I'll be recording this video today for part of our core lecture course at Wills Eye for the residents. This lecture is entitled Clinical Decisions in Cataract Surgery. It's a basic overview of some of the decision-making process as we approach cataract surgery. So, lots of decisions to make. When do I offer surgery? How do I get the cataract out? What lens do I put in? And oops, what now? So when do I offer surgery? Well, in general, when a patient has decreased visual acuity, contrast sensitivity, or glare. But the main key is that they need to have a functional limitation, and that's different for each person depending on the things that they do during the course of their daily activities. And then you want to know, are the patient's complaints consistent with the exam? So someone with a mainly nuclear sclerotic cataract should have a myopic shift. Occasionally, not always, but usually. Loss of near vision is consistent with the posterior subcapsular cataract, and cortical change most commonly presents with glare difficulties, although there is crossover amongst this symptomatology. And then I like to think about it in terms of conservation of vision. So your view in should in general be equal to the patient's view out, except in the case of if you have purely a nuclear sclerotic cataract, oftentimes the view isn't as compromised as the patient's vision may be, but your net vision loss should equal your net pathology. So if the lens doesn't contribute to the net pathology, you're not helping anyone by taking it out. So you got to balance potential improvements in vision with surgical risk. You want to think about anesthesia, such as a patient's medical comorbidities, and their chance of intra or post-op complications. Is this a complex case? A monocular patient, what's their infection risk? And then you do want to think about the practical side of things. Does this meet insurance criteria? So previous insurance criteria included best corrected visual acuity. That actually is not necessary for most insurances at this point in time, although it's still a good guideline. What you're looking for is, again, dysfunction and prognosis that you're going to restore their vision. If you're having difficulty telling what a patient's potential vision is, you can use a potential acuity meter hooked up to the slit lamp or pinhole at near with retroillumination. So you want to have the patient hold the pinhole occluder up, give them a near card, and darken the lights in the room and provide very bright light onto the near card. This is a very simple way to assess someone's potential acuity, because what it does is by giving them one strong beam of light reflected off the near card, is usually able to penetrate through most cataract densities until you start to get to the point where there's very significant opacities in the lens. And then awareness. You want the patient to appreciate the proposed surgery. The only time this might be different is if you're doing surgery for the purposes of visualizing other pathology. So, patient might have mental disabilities, be not able to appreciate the cataract surgery, but has issues with the retina or glaucoma that needs to be dealt with. But these are unique scenarios. And then you want to think, how do I get the cataract out? So phacoemulsification, most common type of cataract surgery in the US. Extracapsular cataract extraction, where you make a larger wound on the sclera or at the limbus to remove the cataract in total. It should be noted that phaco is actually a type of extracapsular cataract extraction. For both of these procedures, you are leaving the capsule intact. Or pars plana lensectomy. Maybe the zonules are totally gone, and it's going to be very difficult to get this lens out from an anterior approach. Sometimes a posterior approach better serves the patient. And you need to ask yourself, can I do what my patient needs? Last thing you want to do is get into the operating room and be stuck and having a problem and not having a way out of it. So let's talk about some things that are important when you're planning your surgery. Wound placement. What do you need? You need placement that facilitates intraoperative technique, reduces astigmatism, and is watertight at the end of the case. In general, we're going for a self-sealing wound. So the way that the wound is self-sealing is because you want to create a flap internally that when you have pressure inside of the eye that's elevated above atmospheric pressure, that pressure is trying to push out, but pushes this internal flap against the external flap. And if the pressure inside of the anterior chamber is higher than the pressure, the atmospheric pressure, then you're going to have a self-sealing wound. That is, unless someone pushes on the wound. And you can still have a self-sealing wound that's resistant to external pressure. It depends on the type of wound you create. So here is illustrating a clear corneal wound, and this is what's called a triplanar wound. So you have partial thickness incision into the cornea, tunneling through the cornea, and then entering in through decimes. And then going further back, you could have a limbal-based wound right here, or here this is describing a scleral tunnel-based wound. Okay, so it's described on where you enter the eye. Clear cornea, limbal, scleral tunnel. So you can see scleral tunnel is a longer wound. It does require some additional surgical manipulation. You can obviously suture the wound, or you can make a very large scleral tunnel wound or an extra cap wound for an M6 surgery, which we'll talk about later. So take this patient for example, 68-year-old female. She's got a diopter of cylinder at 10 degrees in her right eye and 3/4 of a diopter at 180 degrees in her left eye, 2+ NS. Well, one thing to think about is to try and place your wound in the axis of astigmatism. In general, if your wound is temporal or within 5 degrees of temporal, you're going to minimize your surgically induced astigmatism, which typically is on the order of 0.1 to 0.2 diopters if you're using a 2.4 millimeter wound, although that's variable depending on surgeon technique and can be calculated. So if the patient has, against the rule, astigmatism, depending on your handedness, you can sometimes adjust the placement of your wound in order to reduce this astigmatism, because if you operate on the axis of astigmatism, then you can reduce it. This is why ophthalmologists refract and think in plus cylinder as opposed to minus cylinder, because for surgical planning, it is helps to think about where you're placing your incisions. The next patient is a 60-year-old patient, high myope -12, probably going to have a high axial length, 2+ NS. So this would be a person that you would want to start your wound further posteriorly and not tunnel too far anteriorly into the eye. Otherwise, you're going to be operating in a crater and creating wound leak as you try to position your phaco tip more posteriorly in this relatively long eye. Next patient is a 70-year-old male with a history of Flomax use. This would be a person who you would want to tunnel the wound more anteriorly. You don't want to have a short limbal-based wound, and then the iris is going to tend to flop out because you're near the iris root. This next person, older patient, 4+ NS, significant loss of vision. You could certainly phaco this, but you would want to consider whether or not this patient is better served by extracapsular cataract extraction or M6 surgery. And then this patient, a younger patient with PDRs, had PRP, 3+ PSC, patient has vitreous hemorrhage. This would be a person that you would definitely want to put the suture in the wound. If retina is going to go in and do injections or more laser or surgery, having the wound sutured allows them to press on the eye as needed without burping fluid out of the anterior chamber. All right, other things you want to think about are to protect the cornea. So two totally different cases with maybe similar exam. It's important in patients with significant gutata to check the pachymetry. Many optical biometers give this to you on your measurements, but you can also check central pachymetry with an ultrasound. So if you have someone who has normal pachymetry, I think it's reasonable to proceed with surgery. without necessarily having the patient see cornea beforehand. I still discuss with the patient that there's a potential for swelling in the cornea and very small potential for the need for a secondary procedure, i.e. a graft, but in most cases with adequate surgical manipulation, you can protect the cornea. Now, someone who already has corneal edema, as noted by this second here, corneal thickness of 640, they already have significant decompensation of their endothelium. This is definitely a person you want to have a discussion with about potential secondary surgery, and in general, I like to have them see our colleagues in cornea for discussion of a triple procedure, combining things at the same time, or doing a graft first, or just being aware that they may end up spending some time with our cornea specialist in the near future. And then accessing the lens, you need to think about dilation. In this patient, 45-year-old male with a history of uveitis, intumescent white cataract with 180 degrees of synechiae. What do you think about here? Definitely want to use epi-sugarcane and viscodilate. You can lace these adhesions with the viscoelastic cannula. In some cases, you would want to think about a Malyugin ring or iris hooks if you don't have enough pupillary dilation. That being said, in this patient, he already dilates pretty well over here on this side, so that iris is almost too big at this point in time, or the pupil is too big to really utilize ring or hooks. Essentially, you'd be able to visco-dissect this and then should be able to proceed. But with a smaller pupil, you're going to need to put in some additional device. All right, so surgical planning, patient with Flomax. We're thinking about IFIS, or intraoperative floppy iris syndrome. The degree of dilation often corresponds with the degree of IFIS. So if you see someone in clinic that is not dilating well, then you need to think that you're probably going to encounter more trouble in the operating room. So you can consider a Malyugin ring to help with dilation. I also think the Malyugin ring is helpful in this case, even if you have, say you have adequate dilation of 6 millimeters. If you put in a 7 millimeter Malyugin ring, it's going to stabilize the iris and keep it from flopping out of the eye. You can also use other intracameral agents such as omidria to help stabilize the pupil. Remember that iris prolapse results from a pressure gradient and reduced iris tone, so don't overpressurize the chamber. Times when you're going to overpressurize the chamber, or when you're putting viscoelastic in, or hydrating the wound, or going in with the phaco tip. So you can adjust your fluidic settings, but in general, if you avoid overpressurizing the chamber, you're not going to have this iris that has floppy sphincter tone popping out through your wound. Other things to consider for patients with PXF or pseudoexfoliation: you want to be prepared for zonulopathy, even if it doesn't look like it in the clinic. Consider CTR or sulcus IOL placement. These patients do have a risk for delayed in the bag IOL dislocation. This is actually more of a picture of a dislocated sulcus IOL, but this patient does have some degree of pseudoexfoliation. You can see some TIDs related to the sulcus IOL. But again, these patients tend to have in the bag IOL complex subluxation. Trial done a number of years ago by David Chang looked at whether placement of a CTR at the time of surgery prophylactically reduced the risk of IOL capsular bag decentration, and that was not shown to be helpful. However, it is helpful from the sense that if the complex dislocates, having a CTR in the bag allows for certain rescue techniques, whereas if it's a single one-piece acrylic foldable lens, it is more difficult to rescue that complex. Alternatively, you can do sulcus placement of a three-piece lens and do optic capture, also a very good potential technique, and leaves you options for rescue. you want to consider patient age. So, in a patient that is 89 with pseudoexfoliation, and I do surgery, and their capsule looks like it's intact, not a lot of zonulopathy, realistically, you want to consider their life expectancy. And so that patient is one that I'm a little less concerned about than a 73-year-old patient with pseudoexfoliation and moderate zonular weakness at the time of surgery, because that patient is going to tend to dislocate in the future. In the study by David Chang, the mean time of dislocation was close to 10 years. Surgical planning for nuclear disassembly, density matters, and so you can have different techniques that are appropriate for certain types of density. Obviously, every surgeon has a favored technique, and you should go what you're most comfortable with, but it is helpful to have a variety of techniques in your arsenal because not one cataract is amenable to all techniques. So divide and conquer is your traditional technique, where you make a cruciate-shaped groove in the lens and crack that. That's how most people learn initially. Chopping techniques do not create a groove. You embed the phaco tip into the nuclear material, and then you use a second instrument to create cleavage planes in the lens and crack from there. The advantage of a chopping technique is that in general, your forces are directed centrally, so you theoretically have less potential for inducing a zonulopathy, and you have more of your phaco energy that is presented to the nuclear material rather than to the rest of the anterior chamber and the cornea, because with a grooving or divide and conquer technique, part of the phaco tip is not embedded in nuclear material at all times. For softer lenses, you can do a nuclear prolapse or flips, and sometimes femtosecond laser assisted surgery can be helpful in cases of complex cataract, white cataract, zonulopathy, or denser lenses. Although remember, femtosecond laser has to be able to image the lens in order to apply the laser energy. So it is not useful for extremely dense lenses. And the use of femtosecond laser assisted surgery in terms of refractive outcomes is still being debated at this point in time. You can also consider capsular decompression. If you see a white intumescent cataract that looks like the anterior capsule is bulging towards you, it is prudent to consider capsular decompression with a 25 gauge needle beveled down to aspirate some of the liquefied cortical material that's causing that high intracapsular pressure and anterior capsular bowing. If you do not do capsular decompression and your intracapsular pressure is higher than your intracameral pressure, then as you open that capsule, lens material is going to rush forward and you will develop the famous Argentinian flag sign. So these are screenshots of divide and conquer technique. You can see here I'm creating a central groove in the lens, and then I'm starting to spread the nucleus here, continuing to spread. Here's a cleavage plane forming posteriorly, and then I've rotated it 90 degrees. Here's the original groove. Here's the new groove. So here is a real-time video of divide and conquer cataract surgery. I'm a left-handed surgeon, so I'm creating a paracentesis for my non-dominant or my right hand, approximately 40 to 45 degrees away from where my main wound is going to be. I'm injecting intracameral anesthetic. I usually use sugarcane, although this patient is maximally dilated, so not really additional need for that at this point in time. So following this, we're going to inject viscoelastic into the anterior chamber, create an initial bolus, and then I head distally and allow the viscoelastic wave to push fluid out of the eye. So once some viscoelastic comes out, I know I've pressurized the eye. I'm not going to get any more in. And I can go ahead and proceed with my main wound. I like to use 0.12 forceps to stabilize the eye. I put the side with one tooth in the wound, the side with two teeth outside of the wound. I'm using a 2.4 millimeter keratome. This is a biplanar style incision, traveling up into the cornea and then down into through Decimates. I currently create a triplanar wound and create an external groove at the limbus to facilitate accurate starting placement and intact epithelium at the edge of the wound. I'm using the cystotome. You can see I turn it to the side as I go in, starting centrally, working my way out, and then I start to pull down before my intended site of a capsular radius. You can see I started to pull down approximately here, but here is the edge of my capsule, right? And so that then allows me to set my radius properly. If I pull down too far, then too late, then I'm going to have too wide of a rhexis. And you can see me twisting in the wound to drive the edge of the capsule or the rhexis around so that I'm not needing to re-grab subincisionally. Each time I reset my capsule when I grab with the Utrata forceps. And again, when I went in with the forceps, I turned to the side. So when I reset, it allows me to lay the flap over and grab appropriately. And then finish by pulling centrally here. So I'm pretty happy with my rhexis. There's a little bit of oil secretions on the surface of the eye. So I use the phaco tip essentially over the surface of the eye to disrupt the surface tension. That gets rid of the oil secretions there. Just don't phaco the cornea. Here I'm using a hydrodissection cannula, flat hydrodissection cannula. You can see that the fluid wave is starting. There it goes posteriorly. I push down. I always do a second wave to make sure I have good hydrodissection. That's of utmost importance. Press down, and then you want to rotate. You need to be into the epinuclear endonuclear junction to make sure you develop enough torque to rotate the lens. If you're having difficulty with hydrodissection, I recommend using a Chang cannula, as you can hydrodissect subincisionally, and it's also easy to rotate the lens using the cannula almost like a pick. So at this point in time, we're going to go ahead and start with the phacoemulsification. So I'm using my second instrument to lift up the external edge of the wound to get my instrument in. You see how it goes in very nicely there. And then I'm going to stabilize the eye with my second instrument, although as people are learning, oftentimes they use two hands for the phaco. Here I'm just on a higher vacuum setting, clearing up the cortical material. It doesn't matter if you groove through cortical material at all. You want to get it out of the way. So here, starting my groove, you can see that it's cutting nicely through the lens. If you're having difficulty and not going through the lens, you need to increase your torsional power on the phaco unit. I'm taking partial thickness bites, and as I get further down, I do widen the initial anterior edge of the groove in order to allow for the sleeve. I'm taking deeper and deeper bites. As I'm going deeper and more posteriorly, I'm not extending as far because remember the posterior capsule is rounded. If you extend more peripherally as you're posteriorly, it's more likely you could go through the capsule. So I'm trying to assess whether or not I have a deep enough groove. I actually switch my illumination here to almost full coaxial illumination, so it gives me a little bit better red reflex and better sense of where I am with the groove. I'm looking for some of the cortical sutures and chatter marks to change. And then I'm happy with where I am, so I keep my phaco tip down in the groove, Second instrument here, this is a Nagahara chopper going deep into the groove and spreading. I see a cleavage plane form, nice and slow pressure, and then I do a cross action spread as well. So I'm going to rotate 90 degrees. I either drop my second instrument in or I go to the wall of the groove. Then I'm going to start my second groove. I like to take a little bite off of the edge of the heminucleus proximal to me for the first few passes, and then I'll concentrate on the more nasal groove there. Once you create your initial groove and crack, it's always easier to crack the secondary nuclear, the secondary groove. So here again, nice slow spread. Rotate 90 degrees. I'll spread this again to make sure. You always want to see that it spreads centrally. Otherwise, it's still going to be, pieces are going to be locked in. And then again, grooving here. Now I know how deep I can go because I can see how deep it is with my crack. So I've gotten all four. I'm happy at this point in time. Now I can proceed to quadrant removal. So this is a schematic of a vertical quick chop technique. Here I am embedding the phaco tip into the nucleus. I'm dropping my second instrument distal to it, and then I pull towards the phaco tip to create a cleavage plane, and then I move back and I start to spread. And so you can see that I've got a nice crack forming here. And then I rotate, that's my initial crack. I'm phacoing into the material and dropping my second instrument down here again. Here is a video of quick chop technique. This is sped up. We'll go through the steps again. Viscoelastic going in the eye. Here I'm doing that triplanar wound with the edge of the keratome. I just feel it helps to set my depth and wound appropriately. Pivoting in the wound, twisting in the wound, not driving up against the side of the wound to get past the subincisional area with my capsulorhexis. Hydrodissection again, good fluid wave. So here I'm embedding with the phaco tip. Second instrument goes down and in. Very efficient, not wasting any phaco energy grooving. And now I'm pulling the sextants out. In general, with a chopping technique, you need to subdivide into 5 or greater pieces because you're not debulking the nucleus in order to remove the quadrants. It's easier for them to get locked in, and you want to start with the smallest piece first. So I've done the cortical cleanup with bimanual IA, and here's the lens going into the eye. If you have phacodenesis or suspect phacodenesis, you need to be prepared for it. In general, if you see it on examination, it's going to be bad inside of the eye. So you want to be prepared to do an anterior vitrectomy and have some sort of scleral fixation. Other times where you might suspect some phacodenesis but not see it on exam would be if the patient has a history of trauma or poor dilation without a history of IFIS-inducing agents, or with extreme dilation in the clinical lane or angle recession. So a CTR will help to stabilize the capsular bag. It can be used if you have 4 clock hours or less of focal zonular weakness or mild to moderate diffuse zonular weakness. If you remember, the CTR just helps spread tension from one set of zonules to the other. So if you have too much zonulopathy, you need to use something like an Ahmed segment. Down here has this little eyelet you can then fixate with suture to the sclera. CTRs come in different types. You can put it in manually. They're injectable with a screw type. I like a plunger type CTR because I can use a second instrument to stabilize the leading eyelet, and sizing is dependent on the size of the eye. So do you need a larger capsular tension ring for a larger eye? Obviously, if you have a large capsular bag and the ring is too small, you're not doing anything. And then extra cap or M6 manual small incision cataract surgery. You can deliver the lens intact through a large wound. This is useful for very dense cataracts. Why? Well, you don't have phaco time, so you're not transferring phaco energy to the cornea. And potentially loose complications can be helpful in cases of a zonulopathy, although typically that's in the hands of someone who's a talented M6 surgeon. It is easy to prolapse the capsular bag with the lens in a significant zonulopathy. So traditional extra cap has a shelved limbal incision requiring 8 sutures. There's risks for induced astigmatism with this, as well as if the patient sustains an injury to the eye, expulsion of intraocular contents out through that wound in a delayed fashion, even years down the road after the sutures have been removed. So M6 is no sutures, so there's less astigmatism and less surgical time with an experienced physician. So I, as an unexperienced or moderately experienced, I should say, M6 surgeon, I can do a case in about 20 to 25 minutes. Surgeons who are doing this in the majority world can do a sub 10 minute case routinely, whereas phacoing a very dense lens can easily be over an hour case. So less post-op time, and the wound is more intact if the patient sustains an ocular injury down the road. Because it's a long tunnel, you're less likely to have any expulsion of intraocular contents. So here's a brief video of M6. So I've done a peritomy. I'm using a blade to create a partial thickness scleral tunnel in kind of a frown fashion. And then I'm using a crescent blade in order to tunnel up into clear corneal. So you can see the very long and wide incision. I've created a large capsular rhexis. I've hydrodissected and I'm rotating the lens out into the anterior chamber. I'll place viscoelastic behind the lens. This is an irrigating vectus, irrigating fluid into the eye, pushing on the posterior lip of the wound and allowing it to prolapse out of the eye. This is a Simcoe IA. It's manually controlled. You can see some chamber fluctuation related to going through the main wound. This is a 3-piece IOL going into the capsular bag, and the wound is well sealed at the end of the case, although I often put sutures, 1 to 3 sutures, just to help me sleep better at night. And then I will close the conjunctiva with cautery. You can use vicryl suture. So you can see here, no corneal edema. This patient will do quite well. All right, so thinking about what lens you put in. We talked about how to get the cataract out. Now we're talking about what lens to put in. So what are the patient's expectations? What do they think their vision is going to be like after surgery? And being a cataract surgeon or an ophthalmologist in general is a little bit being like a part-time psychologist. So you need to quickly get a sense of the patient and their expectations and meet them where they're at and direct them with where it's possible to go. So the big thing to ask is, do you read without glasses? Because if people are doing tasks at near without glasses and they're in an age range where they've lost accommodation, which most cataract patients are, then if you just set them for plano at distance, they're going to lose some of that near and they're going to be quite unhappy. So always ask, especially with a myopic patient, do you read without glasses? Because you want to consider conserving that myopia. And how important is it for you to be glasses independent? Some people would love to get rid of their glasses and pursue a presbyopia correcting lens or an astigmatism correcting lens. Other people have worn glasses all their life and they like glasses, or maybe they are in a profession where they could readily get hit in the eye with something and it's beneficial for them to wear full-time glasses. So I ask about their work, about their hobbies. If they're nearsighted, I list examples. Do you read in bed without glasses? Do you put makeup on without glasses? Do you work on small crafts without glasses? You really want to figure out where the patient is functioning and then reconcile this with what you can deliver. Now, do you do a plano aim? Do you do a near aim? Do you do a version of blended or mini mono vision? Studies have demonstrated that there's a good preservation of depth perception with less than 1 1/4 diopter spherical equivalent difference, although some patients can be more sensitive. If a patient's done monovision in contacts, this is a slam dunk. Just recreate that with cataract surgery. Or you can consider multifocal, trifocal, extended depth of focus lenses. So, again, mild myope, consider leaving them myopic. For a high myope unilateral cataract, are they a contact lens wearer? Can they wear a contact lens in their other eye? Do you want to set them plano? If it's a patient that's post-retinal detachment and has a cataract because of that, those patients are going to tend to be more myopic. If you make them plano in one eye and they're myopic in the other, they're bound to using their contact lens all the time. You can leave them more significantly myopic, although that does bind them to being myopic for the rest of their life. Again, some of those patients like that. That's how they're used to. Hyperopes are a good candidate for multifocal or extended depth of focus lenses because once they're in the presbyopic age range, they just have poor quality vision across all distances. So that's different than myopes who, until their cataract is bad, have preserved good magnification and contrast at near. So hyperopes tend to adapt well to some of the mild trade-offs in contrast sensitivity that can come with some of the presbyopia correcting lenses. Patient has astigmatism, you obviously want to consider correcting that. You can use a toric lens, femtosecond laser assisted arcuate keratotomies, or limbal relaxing incisions. Contact lens wearers, again, consider monovision. Young patients need to be cautioned about absolute presbyopia. So if you take a 45-year-old -1 diopter patient who has a cataract and you make them plano, all of a sudden they have no accommodation in that eye. And their other eye can often pick up the rest of the work if they don't have a cataract in that eye. But if you make them a bilateral pseudophakic, you have to be very clear about their expectations for reading glasses because they have no frame of reference if they're plano OU. You have to discuss that with them. And then post-LASIK patients are expecting perfection because they have perfection from their LASIK. So you obviously want to deliver this to them, and there's a lot of ways we can do this, but you be prepared to sit and have some chair time with these patients. So in patients with pseudoexfoliation syndrome, especially if they have astigmatism, we talked about this earlier, but you want to be careful about what lens you put in. In general, it's safer to correct the astigmatism on the cornea if it's amenable to that, although you can only correct maybe about a diopter and a quarter of astigmatism on the cornea with LRIs or arcuate keratotomies. So you could reduce the astigmatism in this patient, maybe not eliminate it completely, but these patients can have delayed lens decentration, and so remember the toric correction is dependent on the axis of where the IOL is, and so this is dependent on rotation. If the IOL shifts and it shifts laterally, then in some cases you create an error in the vector calculations and you can induce more astigmatism. This is very important with multifocal IOLs as well because in these patients, if the lens is decentered at all, they're going to have decreased contrast sensitivity and visual acuity. So I would hesitate and caution you against placing multifocal IOLs in these patients. Another example of a young person with PDR, history of vitrectomy already, had vitreous hemorrhage. In a young patient, maybe they're not compliant, maybe they're going to have hemorrhage again or traction. If they have some degree of TRD, you got to be very careful. I do not put silicone lenses in my diabetic patients for this reason, because if they ever have silicone oil in the eye, you're going to get oil droplets on the back of the lens and have to take it out. So I avoid silicone lenses in these patients. I also avoid multifocals in these patients. You don't know how people with retinopathy like macular degeneration or diabetic retinopathy are going to progress over time. That's different than something like an ERM that's already been peeled or a mild ERM that could be amenable to peeling in the future. somebody with potential progressive retinopathy over time, be again careful about multifocal IOLs. And I would suture the wound in this patient and talk to my retina colleagues if they think they're going to need to go back in. All right, here is an example of iris prolapse. This is in a patient with IFIS syndrome. And so, the tendency is to want to shove the iris back in through the main wound, but this is not what's going to help you the most here. What you want to do is decompress the chamber. So go to your paracentesis, push down on the paracentesis, and let some pressure out of the eye. And then go in through the paracentesis. With the viscoelastic cannula is usually what I use. And then I'll go sweep the iris back into the eye. And I can also place a depot of viscoelastic to help it from coming back out. So if you have a radial tear, you can do the little maneuver, which is well described. What you can see here is that the person was doing the capsulotomy started to go out. And so what you're doing is when you do the little maneuver, rather than folding the tear over, you're driving it back and away from your initial axis of the tear. And so what this does is creates a tighter radius of curvature. You can almost think of it as like two circles onto your existing circle of your capsular axis. Oop, a little too wide there. And so that will help bring it back in. If it's gone out to the equator already, sometimes when it's in the zonular complex out there, it's hard to get back in. You can also do a beer can capsulotomy. What you're doing is creating multiple radial elements. I don't know who would drink a beer like this, but that's what it's called, or a can opener capsulotomy. And so once you create multiple radial elements, you decrease the risk of radialization. Technically, once you have 3 radial elements, if they're equal in size, then you should have it less likely to radialize. If I have a partial continuous rexus and it tears out and I need to do a can opener or beer can capsulotomy, I will go back to the area where there was the continuous rexus, and I will make some little nicks in the capsule to adequately distribute the radial elements. Posterior capsular rupture, you want to maintain irrigation. Don't rip everything out of the eye. You want to place dispersive viscoelastic in the rent prior to removal of the phacotip. This is an OCAP question. And you want to look for vitreous in the AC or in the wound. Sequester nuclear material in the anterior chamber with viscoelastic. Bimanual vitrectomy if needed. Cut IA or triescence. In a best case scenario, if you notice there's a rent, place some triescence into the eye after placing a small depot of viscoelastic at the area of the rent. And then that way the triescence can circulate through the anterior chamber and stain the vitreous. If you have a lot of viscoelastic in the anterior chamber already, it is hard for the triescence to adhere to the vitreous amongst the viscoelastic. If you have any of these problems as a resident, and you will, you want to look at them as opportunities to learn how to handle it well. The last thing you want to do is have these problems when you're by yourself operating. So obviously you don't want to have more complications than necessary, but try to look at these as learning experiences. And I would also encourage all of you to record all of your cases. You never know when you're going to have a problem, and having the opportunity for video review when you do have a problem is one of the most helpful ways to prevent a future problem. Thanks for listening. Please feel free to reach out to me with any questions.